So Dr. Ulmen joined Carroll University Nursing Department in the fall of 2021. She has over 24 years of nursing experience with a major focus in the trauma emergency room setting. Dr. Ulmen has been working in higher ed for over 8 years. She has taught across the nursing curriculum, including clinical instruction, online teaching, and in the classroom for traditional undergraduate, BSN completion, and MSN students. She credits her mentors for helping her identify her passions and development in the nurse educator role, and aspires to do the same for all her students. So what I'm going to do now is I'm going to turn the floor over to you folks. I will set a timer for 25 minutes. When my face pops back up, we'll have about 5 minutes to close up and ask final questions. And you'll have a couple extra minutes because we are, again, a little bit ahead of schedule. Okay?
All right, I will start. I am Dr. Cynthia Witte. I'll just do a quick bio, and I'll also allow my colleagues to do a quick intro before we actually start our presentation, just for flow purposes. So I have a background of 23 years in nursing education, 20 years of professional clinical experience. My expertise, just briefly, medical surgical nursing, also clinical nursing education. And my Doctor of Nursing practice, I obtained through Rush University College of Nursing, and that was an emphasis in leadership in the business of healthcare. And my project was primarily focused on orientation and mentoring program for clinical nursing instructors.
I'm Sam Speckhard. I'm also a faculty member at Concordia University. I've been in nursing for a little under 10 years. This is my third year in the academic world, and one of my first conferences. So I'm pretty excited to be here. Yeah, most of my background is in med-surg and intraoperative nursing, where I've worked with specialty clinicians with sickle cell anemia.
Good morning, everyone. I'm Dr. Cindy Fenske. I am the chair of nursing at the program at Concordia University, Ann Arbor. Cindy and Sam and Brenda, Brenda formerly, were part of Concordia University, Wisconsin, and so we're a multi-site of that program. I am closing in on 40 years of faculty work, focusing mostly on undergraduate teaching. My passion is simulation and the use of experiential learning tools to better train nursing students. And so when we started the nursing program here in Ann Arbor, the focus is really focused and keyed in on the use of simulation, and we use a great deal of it. So it really fit nicely with this the project that we ended up doing.
Really quickly, can everyone see the slides?
Yes, they're beautiful. My favorite color.
Excellent. Thank you. I did that on purpose.
All right. Well, greetings then from Wisconsin and Michigan. It is an honor and pleasure for us to be with all of you today. So we would like to share with you this morning our findings from our study titled Transition to Practice, the Use of Virtual Clinical Replacement During the COVID-19 Pandemic, and its impact on new graduate nurse readiness. So the aim of our study was to investigate graduate nurse readiness for practice after receiving virtual clinical replacement experiences during the COVID-19 pandemic. So we all know that the pandemic had a significant impact on healthcare education, resulting in the cancellation of student clinical experiences. And so many educational facilities had to make that quick transition to virtual clinical replacement experiences during this time. And so Dr. Cindy Fenske will provide you with some further background information.
Yes, I'll start with that background, and I'll talk a little bit about what led to our decision to do this study. So as educators, we're well aware of the issues that our graduates face as they transition to practice. So when the pandemic hit, we had concerns about how new graduates, even around the world, which you'll find out this is an international study, would fare as they moved into this role of a nurse. We are aware of that a successful transition to practice from student nurse to graduate nurse is an essential factor in the satisfaction of both the hiring organization as well as the nurse. Even under typical circumstances, the new graduate may experience feelings of inadequacy, stress, anxiety, a lot of uncertainty about their ability to safely meet the demands of the job. Additionally, we know that new graduate nurses frequently lack confidence in their technical skills, in their clinical judgment skills, in their ability to practice independently. Nursing faculty work to teach students how to integrate the content knowledge and the skills ability with their practice experiences, but it's become apparent that there's a gap between undergraduate learning and the level of clinical decision-making that's needed to practice at a competent level. Nurse leaders' impressions of many new graduate nurses is that they are not practice ready, particularly in their level of competence in clinical knowledge. And as we mentioned, comfort with technical skills. Again, that's always a problem. A lot of difficulties with critical thinking abilities. They have challenges with communication skills with both patients and other healthcare professionals. There may be some issues with professionalism and as well as management of responsibilities, a lot of organization issues that they are challenged with. The ever-growing challenges within the healthcare system, including staffing shortages and increasing patient complexity and acuity, add to the difficulty for the new graduate nurse to transition into practice. New graduates begin their career with a strong background in knowledge or in evidence-based knowledge, but lack clinical judgment to manage the complexities of the patient care. The gap between educational preparation and clinical practice needs to be bridged with transition programs that provide significant support for new graduates to reduce this frustration, improve self-reflection of their abilities, and to gain that self-confidence that they are lacking. The goal of nursing education programs is to provide students with that foundational information to successfully transition into practice. Unfortunately, many new graduate nurses express concerns about this difficulty in applying what they've learned in school to the actual practice of nursing. And again, it results in lack of professional competence, feelings of uncertainty, isolation. And as we're all aware that new graduate nurses report that in their first year of practice as a registered nurse, it's very challenging and it's a very stressful time. They cite specific concerns such as stress related to this interprofessional communication issue that's important, clinical decision-making, technical skills, and being able to perform those independently, and having a lot of difficulties with organizational skills. What they do show when within literature searches, factors that have shown to promote confidence in this professional role development and adaptation include things such as formal orientation programs, supportive and positive supervision, a welcoming collegial clinical environment, intentional mentoring, and the use of simulation. As we know, many hospital facilities will use simulation as an orientation and teaching tool. As Dr. Witte mentioned earlier, once the pandemic hit, it influenced the majority of countries around the world. It definitely hit Wisconsin and Michigan hard, and it eliminated, in our cases, it eliminated the opportunity for any kind of face-to-face clinical experiences. I know that everybody was not impacted to that extent, but here they were shut down instantly. They were done and over with. And so people had to switch and transition on a dime to determine what are we going to do to replace these really important experiences. And if you think about it, when it hit in the middle of a semester for most people. Those students had the remainder of the semester, hit us right about midterm, to complete their probable capstone experience before they would move on to transition to practice. And then we also know that the lack of clinical experiences continued as summer semesters continued and even into fall. So we began to look at virtual clinical replacement experiences. I'll have you change that slide, Sam, please. Thank you. So as we are well aware, clinical practicum is a key component of this role development and role socialization. And this is the place where the students have the opportunity to practice what they've been learning in school and apply it to this actual situation. They get to the opportunity to actually communicate with other healthcare professionals and to establish relationships with staff and patients. This is where they really get to apply what they've been learning. And when all of these clinicals were canceled, it was an immediate loss of that opportunity. To fulfill the remaining and required clinical hours, some students or schools or programs used a form of virtual clinical replacement. So some examples of these, and you'll see us abbreviated occasionally here through as VCRE, so virtual clinical replacement experiences. They include things such as web-based products. There were other products that might include a variety of multimedia assets to reproduce an interactive clinical experience, an interactive learning experience. It might be recorded clinical simulation scenarios. Perhaps, I know one of the things that we used was that we had we'd had simulations that the students had participated in previous semesters. We were able to pull those recordings up and use them as a stopping and a starting opportunity for students to observe and then respond. It also could include things such as augmented and virtual reality. A lot of these tools were used to simulate things such as a clinical day, decision-making scenarios, medication administration, for example. What we discovered is that limited research had been done on the effectiveness of the virtual clinical replacement experiences to prepare new graduates for transition into practice. There have been some reviews of the literature where they looked at the types of simulation and how they worked in terms of nursing education. And overall, we know that the virtual clinical replacement experiences have been found to be effective with teaching and learning. They're effective for knowledge acquisition and for skill training. They have been shown to improve knowledge retention, clinical reasoning, and student satisfaction. They also have shown to improve learning that not only occurs initially, but also has improved retention as well. So now we'll move into the actual purpose and methodology of the study.
Yes, thanks, Cindy. So the purpose of our study, like I said, was to examine the perception of readiness for practice of new graduate nurses who completed some portion of their nursing school training during the COVID-19 pandemic and who experienced some form of virtual clinical replacement in the process. So our research methodology and design resulted in a descriptive correlational study using both quantitative and a qualitative approach. We utilized the Casey Fink Graduate Nurse Experience Survey, which consisted of 5 sections that addressed demographics, the comfort level in independently performing skills and procedures, the degree of stressors in the work environment. It also looked at job satisfaction and difficulty in role transition. In addition, the participants were asked to share comments or concerns related to their residency program, if that was applicable to their situation. It didn't apply to all. And then we also, to just provide a better understanding of the impact of virtual clinical experiences on participants' transition to practice, We generated 3 additional questions. The first question being, do you believe your virtual clinical experiences adequately prepared you to enter the nursing workforce? The second question we inquired on was how much time was spent in virtual learning. And then the third question was inquiring, did they continue to work in healthcare during their virtual learning? So the survey was distributed using Qualtrics software, and a homogeneous purposive sampling was used to recruit 124 participants from the United States, Australia, New Zealand, Canada, and the United Kingdom. The data was then uploaded into the statistical package for social sciences for statistical analysis using descriptive and independent t-test analysis methods. And then in addition, participants were asked to share some narrative comments regarding their residency experience at their place of employment. These responses then were analyzed independently by each of us on the research team. And then using a general inductive approach, we identified and came to a consensus regarding the common themes that were embedded in their responses. So our population sample included Bachelor of Science prepared registered nurses who had at least 1 semester of their education interrupted by the effect of COVID-19. Recruitment of participants was done through email communication, indicating the purpose of the study was again to research graduate nurse readiness post virtual instruction during that COVID-19 pandemic. And the survey was open for 12 weeks. So we kind of started this November of 2020 to February of 2021, looking to capture about 2 semester worths of participants. The required sample for a medium effect size was 111 when using a G-power of 0.95 and a significance level of 0.05. Fortunately, as mentioned earlier, we were able to recruit 124 participants for our study. And Dr. Brenda Ulmen will share our findings next.
Okay, wonderful. So just to give you an idea of the general demographics of our participants, the average age was 25 years old, typically female, Caucasian, and the majority of our participants worked either day shift or they worked night shift. Orientation for new graduates ranged from 8 to 24 weeks, but the majority reported about a 12-week orientation. Preceptors ranged from 1 to 15, but the average was about 3.41. 48% of the participants spent greater than half of their semester in virtual clinical simulation, and this was all self-reported. 57% of those felt it was beneficial, and 62% continued working in healthcare during that time. In this table, you will find the different types of virtual clinical simulation and the percent used reported from the participants. We had these listed out for them to choose from, so you can see the ones that were essentially most popular that the majority used. And then we did have a category for other, which those were not listed. But as you can see, we covered a vast amount of clinical replacement experiences that were used during this time. So just to repeat, the stressors in the work environment were categorized into subskills, including support, confidence in patient safety, communication and leadership skills, professional satisfaction, and personal stress. I just want to say to begin with, the personal stress subscale, there were questions that were really focused on external factors, so we did not analyze those for the purpose of our study. We used independent t-tests, so we took the means of the subscale of the stressors in the work environment, and we compared those against the group of participants who answered those researcher-generated questions. Again, just to repeat what those were, it was whether their virtual clinical experiences adequately prepared them to enter the nursing workforce, the percent of time spent in virtual clinical experiences, and if they continue to work in healthcare during the virtual clinical experience. Again, just to start off, the time spent in virtual clinical was measured in quartiles and it was self-reported. However, there was no significance found with that. Our results did show that those who continued working in healthcare during virtual clinical replacement was statistically significant with higher levels of communication and leadership. So what that means is participants who worked in healthcare while receiving virtual clinical reported higher levels of confidence in communicating and their leadership skills when starting their role as a new graduate nurse. The other subcategory showing significance was patient safety. The participants who continued working in healthcare during their clinical replacement during virtual clinical replacement was significant with patient safety, meaning that new graduates actually reported higher levels of confidence in providing for that patient safety when starting their role. Independent t-tests, again, were used to compare the participants who perceived their virtual clinical replacement experiences adequately prepared them to enter the nursing workforce against the subscales of support, confidence in patient safety, communication and leadership skills, and professional satisfaction. As you can see, support and communication and leadership skills were significant with those participants who found those virtual clinical replacement experiences beneficial. So what this means is those participants who experienced virtual clinical replacement experiences and found them beneficial had higher levels of support in the workplace and felt more confident with their communication and leadership skills in their new role. Many of the questions generated on the Casey-Fink survey provided frequencies for our results. So over 70% of the participants felt comfortable acquainting themselves with the unit, learning technology, and developing a good relationship with their preceptors. 73% felt well supported with positive feedback and encouragement from their preceptors, their manager, and other staff. As you can see in the first comment here, and these were the questions where they were able to provide narrative comments about their orientation and residency program. So as you can see in this first comment, I feel very supported as I start working as a new grad. My manager and unit educator were understanding of our transition during COVID. However, 42% of participants reported unit orientation could be improved with greater support and consistency of preceptors, extending orientation time and providing better opportunities to practice unit-specific skills. Remember that the average number of preceptors ranged from 1 to 15. So those with numerous preceptors could have struggled with that consistency that they're talking about here. The second statement here listed indicates that participants felt a severe lack of available preceptors. The orientation time varied from less than 8 weeks to as many as 24, but the average was 12. As you can see, some participants reported their orientation and residency program was cut short or canceled, causing them additional stress. 48% of participants struggled with organizing and prioritizing their overall workload and felt that the work environment could be improved by providing better patient ratios and getting more help on the unit, like in terms of additional nurses or CNAs. In the last statement, this participant reported that those patient ratio changes were a result of understaffing and led to what felt like an unsafe environment. They also reported dissatisfaction in schedule conflicts due to the understaffing. And again, despite some of the positive findings that we found in this study, it didn't negate the fact that 57% of participants reported feeling fear in their transition to the new graduate role, with 66% reporting that they lacked confidence with delegation and critical thinking. As you can see in the comments here, participants felt that their semester being cut short or changed due to COVID, it affected their ability to perform as they would have liked in their new role.
Okay, thank you, Brenda. So as we just went through, there was a lot of statistical significance with this survey. Now, there are two main takeaways, I think, from that if we group some of this together. And I want to start with the fact that graduate nurses who continued working, others like nursing assistant or maybe a HUC or some other hospital related job, had reported increased confidence in patient safety, as well as increased confidence in their leadership abilities and communication skills. We think this likely happens because that workplace experience is an in-person experience that wasn't robbed of them from COVID-19 or the shutdown of clinical experiences. So while virtual clinical replacement experiences can be very helpful, there is a difference between in-person and those virtual opportunities. So if they still get that context in the workplace, it can help them feel comfortable with those things. Now they're not working as nurses, but they're working alongside nurses. They're talking with nurses. They're observing nurses doing the job that they're hoping to do shortly after. And so being able to have those experiences is extremely useful whenever they can. I think that as faculty, we tend to look at nursing students that work a lot, potentially as that work being more of a burden than a boon. And I think this study really points out that when the clinical experiences are not there, there really is some benefit to having work, obviously within limitations of not cutting into your schoolwork and whatnot. Considering that the pandemic is not the only reason why we might lose a clinical experience or some of an experience, like where we teach in Milwaukee, we have a lot of very good nursing schools around here that are very competitive and all fighting for those experiences. So if we have to supplement some of that with virtual replacement, having this work experience can be really helpful, at least with these sections of the survey results. The other really big discussion takeaway point is that graduate nurses who found the virtual clinical replacement experiences useful noted increased recognition of support in the workplace, and they were more confident with their leadership skills and communication skills. Now, we have to remember that over half, but not too much over, of students said that these were beneficial. And that'll kind of come into limitations where we have to think about how many different things qualify for these experiences or what types there are. But we think that this occurs because a lot of these exercises are less about physically applying our skills and knowledge, but applying them into scenarios where we all get a little more time to communicate with each other. We had a lot of case study implementation in our program as a result of replacing our clinical experiences. And a lot of our faculty who led those discussions with students were pleasantly surprised by how much time they had with each student. When you're not running around trying to give meds and perform skills, and you can just talk about the patient and the plan of care and how you would implement it, you get a lot more time to specifically check in with students on their understanding of these concepts and make sure that everyone's kind of working together on it. So we think that these virtual settings can offer a lot of good opportunity for communication practice and also collaboration. Which maybe considering some of these are asynchronous might be surprising, but we think that it might have to do with that. This is really important because as we learned in the very first presentation today, students need interprofessional teamwork and care experience, and all of these skill sets, leadership, communication, and then also knowing how to seek help, part of that process of knowing what the roles are for everyone on your healthcare team and being confident in reaching out. That's especially important because, as we saw in the last discussion comment, and as we all know, just even when there isn't a pandemic, is that graduates typically are not ready to be independent day one when they get out of school and they pass that NCLEX. They have to go through an orientation program, which might have been cut short. But regardless of that, it's almost more important that they feel comfortable with and know how to appropriately ask for help and get assistance during that first year than expecting them to know everything from the get-go. So if they are more confident in those things, they're much more likely to be successful during that period. And this is very much in line with the research that we saw when we did our literature review and we looked up some additional stuff after we got our survey results back. But it also is really important towards retaining your graduates. So that first year is obviously really hard, regardless of whether there's a pandemic or not. And so with that, you have to be able to have something positive that people can hang on to and feel supported, feel like they belong as a part of a team, that they've got people they can go to when stuff is tough. And again, those skills are very social related, so they can end up working a lot better with their teammates, bonding with them, and hopefully that will help them make it through one of the hardest years of their life. And now we've got Cindy with limitations.
All right, thanks, Sam. So a limitation to our study was the use of a convenience sample. Those that responded to our survey may not be representative of the general population of graduate nurses. And then also, you know, some geographical locations may have been more restricted or impacted by COVID-19 compared to others, as Dr. Fenske had, you know, alluded to earlier as well. And so participants may have had more or less time using virtual clinical replacement experiences. Another limitation that we realized is that virtual clinical replacement experiences can encompass a wide range of different activities. And Sam alluded to that as well just a few minutes ago. So as we noted, you know, case studies and or software-based simulation were commonly utilized. However, the activities may have been designed or modified or used differently by instructors depending on the learning situation, you know, that they had. So the level of individualization could have resulted in variations in like the delivery method or the quality of the different learning experiences, which again could potentially change the impact, you know, it had on students. It's also important to note that a comparison was not conducted between individual virtual clinical replacement experiences and the students' perceptions of the effectiveness in our study. So we also take that into consideration. So our study demonstrated that virtual clinical replacement experiences are a beneficial and accessible substitute when clinical cannot be held in person. However, you know, we realize virtual clinical replacement experiences are not necessarily beneficial for every learner. You know, there are different learning styles to consider. You know, some definitely may be more auditory, but definitely there are many learners that are very kinesthetic with hands-on. So to fully understand the benefits of virtual clinical replacement experience, you know, further research is needed to compare individuals that did not have virtual clinical replacement experience exposure to those that did. Also, further research, you know, is needed to examine the effectiveness of individual types and methods of instruction when using virtual clinical replacement experience for clinical hours. And also finally, you know, virtual clinical replacement experiences did not show a correlation between usage and organization and prioritization skills. So again, another area for future research, you know, could focus on determining like what types of virtual clinical replacement experiences have the best effects on these skills, and if virtual clinical experiences, you know, can improve those organization and prioritization skills. And so in conclusion, the COVID-19 pandemic significantly impacted the delivery of clinical education in nursing schools around the world, resulting in the loss of clinical placements. The loss of expected learning experiences really challenged educators to develop real life experiences in a virtual or online format. Though the loss of expected learning experiences may have contributed to the participants' overall fear of transitioning to their graduate nurse role, the unexpected gains from virtual clinical replacement experiences were that again, participants felt greater confidence in providing for patient safety. They had stronger professional communication and leadership skills, and they also reported feeling high levels of support in the workplace. And so, and those, you know, were our main findings and significant findings for our study. So the next few slides are our references for anyone who is interested. And as we kind of page through those, that brings us to the end of our presentation. So thank you for listening. And are there any questions?
Wow, you guys have time to spare as well. 5 minutes or so left on your presentation time, and then we have another 5 or 10 minutes for talking. So plenty of time for questions. Does anybody other than me have comments or questions? Because you know I do, but I'd hate to hog the show. So we'll give someone else a chance before I start. I don't see any in the chat. So let me start while they're thinking. So I do chuckle. I was at a interprofessional educational leadership conference last week in person down in Atlanta. And the chairman of that conference, one of his statements, and this was PAs, OTs, PTs, MDs, nursing education. It was practice side as well as education side. And his statement, one that I was like, wow, he said, you know, I know many people shut down clinical during the pandemic. We lost valuable learning. And in places where they didn't shut it down completely, they actually were able to add the students in because of lack of staffing and truly allow those students to learn and benefit during the pandemic instead of letting them sit at home. And he said, we did that wrong. We should not have shut it all down. And I was like, oh, it's the first person I've ever heard say that out loud to a group of people, that we were wrong for shutting it down. I'm like, sweet. And this that you folks have said, those students that worked in healthcare while they were in school, you know, working a different job, but being in nursing school, of course they did better. They got to see it, you know, front row and learn all the theory and whatnot from behind. How valuable is that? I really enjoyed listening to what you had to say. So any thoughts on on the chair from the last conference I was at, his statement? What do you think?
In this area, the hospitals would not allow us to come in for clinical, but they hired all of our students. They called them nurse extenders. And so numerous amounts of them were hired to be like the hands of the nurses who, if you remember, just because of the equipment, the IPE that was needed, they were all in the rooms and they ran kind of, you know, they would run back and forth and get supplies and help and do the work on the outside of the room, making sure that the nurse was able to have whatever they needed. So you think it's a little bit ironic. We're not allowed in the capacity as a student to learn and help, but they were allowed in to work.
Do you think it had to do with insurances and not being sued for a student getting sick? That
Probably.
would be
100%, very much so. In all honesty, when we first got this group together to start looking into this kind of stuff, a few of us joined up because originally our initial questions were, you know, is there a possibility that we could actually start working more closely with our healthcare partners to create paid clinical experiences like they do in California, is to not only give those students more meaningful work experience because they would be given additional responsibilities and skills, but that they could also be secure with their availability and placement, even if there's a shutdown because they're working there as an employee. You know, a lot of other potential benefits from that and whatnot. And we saw, again, parallel benefit here in the study. So yes, I do think that, you know, it's not that we all didn't get sued and our students were mostly safe from all of that. But I do think that they did miss out on something. And luckily the VCREs are showing to have covered some of that loss. And they do have their part in this process. But yeah, I can't help but agree with what he was saying.
Well, do you think with your study and other evidence that's going to come out of all the places that had to use this virtual clinical, do you think we'll find more boards of nursing willing to allow the combination of virtual / simulation in conjunction with in-person clinical. I know when I was an administrator in Ohio, the only ones that were allowed to use anything other than on the floor clinical were the peds and OB folks. I was one of those because there were so few slots, and actually getting clinical placement was like kind of a, oh wow, we did something special. But they allowed us to use simulation 50% in those two specialties, just because of lack of places to put our students. What do you folks as educators think? Do you think we'll see more boards of nursing lightening up on that?
I really hope so. In our case in Michigan, they allowed 100% of clinical to be replaced for all with simulation for all aspects, and it went for a year. It's now rescinded. Under normal circumstances, Michigan will allow 50% for each clinical specialty or for each course. And I'd be curious, other people in the audience, what their state board is allowing.
Oh, and let me clarify that in Ohio, that was before COVID. Like during COVID, they certainly had to do something else. And
Yeah.
I was in Pennsylvania at the time.
Yes,
but
50% for us is before and after. Yeah, but during it, you're right, it was 100%.
Yeah, I'm curious too, who else in other states, what do your boards of nursing allow? And I'll check the chat box too if you don't wish to. Virginia allows 25% of simulation now.
Yeah,
But
so does Louisiana, 25%.
Okay, because I think we might find that when you pair the two well, like you folks have shown in the study, it can increase some things that we have trouble increasing just on the floor. Because who gets to talk to the administrator or the doc when they're on the floor? Unless you're a medical student or someone else, because nursing students don't mind it.
I would say that the only reason why I would think that people won't necessarily jump into this is for the same reasons that they want to shoot for ideal goals. I mean, we look at our educator requirements in the state of Wisconsin and how they are really pushing for clinical instructors to have master's level degrees, that our faculty in the universities are getting those PhDs and doctorate terminal degrees. I think that the only times like some of those things get relieved is when they look at it and say there just aren't enough people to make that a reality. Like it's just not realistic. And I think that could be a part of how we can ease our way into offering more clinical opportunities, is like when we have things like COVID and it was unrealistic to meet our regular requirements. Now we get to look at that stuff and say, like, are these students actually going to be okay? And if they are, maybe we can lighten things up again. Or, hey, like a lot of these hospitals don't have enough opportunities for our schools. The state's going to have to make changes to allow for more virtual experiences. And then from there, as long as we're doing a diligent job of checking that and seeing like, what are the results looking like, pass rates and retention of hire and stuff like that, which is a lot of data from a lot of different places and obviously very hard to keep track of. Maybe we can see some positive change towards that.
I would agree with that. I would hope we would anyway. And then, of course, now I'm going to throw some other words in here that I just chuckle at. Then you've got the Gen Zers that don't stay anywhere long. If they don't like it, they're going to move on. They're not the ones that'll stick it out. No, I'll wait my year. A lot of them will move on no matter what. So I think there's, like you say, there's all kinds of factors that play in. But I liked what I heard as far as, the leadership and whatnot that you saw. It was good from simulation and virtual clinical. So it's great.
Can you hear me okay? Is my
I can
audio
now.
working? Okay, all right, awesome. I just wanted to say, when we originally began this study, or when we started to think about how we were going to construct this study, my thoughts were that there was not going to be such positive results. I kind of figured that with the emotion and the stress of COVID and, students being so overwhelmed and I think really like the mental health issues that developed during that time and then going into the hospital and starting their role, that there would have been a lot more negative results regarding our inability to provide that education in a great way. And so when we came upon these results, I was I was a little bit dumbfounded, like, oh my goodness, like this is awesome. Like it worked, and I think it's so wonderful as an educator when you have to come up with something on the fly like that and then, pray that it is well received and that they learned from it and that it actually helped them in their role. I think it provides us a lot of sound evidence moving forward in that this really does work. And think about how fast we had to provide that. And now we can be prepared and actually plan for it more and have that even more developed than it was during this time, because when we did this study, we were really kind of going back in time to say, what did you do? What did you have? We weren't looking forward thinking, what can we do? So I think it was just a pleasant surprise, the results that we got, and knowing that that we served our students well.
Absolutely. So my next question is, are you folks publishing this somewhere? And if so, what journals are you looking at? Because it's something I wish to have in my arsenal when people start talking about, can we use this and have positive effects? Yes, no?
Brenda, go ahead.
Sorry, I didn't want to steal all the answers here. Yes, we actually just got accepted for publication in Nursing Education Perspectives, and it will be published in the September-October issue of this year.
Cool. I will look for it because it's a valuable tool for all of us in nursing ed when we're looking at what boards of nursing will allow us to do and how we build things now going forward.
And I think it's even important. I think it's even important for student buy-in as well, because I don't know about other educators out there. Sometimes students don't always see the benefit in simulation, or feeling like they're talking to someone who's not real or going through these situations. And we have some clear evidence that this actually does prepare you pretty well for practice. And so that I know there's lots of things out there saying that with simulation or virtual clinical experiences, but I think any amount of evidence that we can provide our students that it might not feel like it, but this works, I promise you'll feel better. It helps.
Right. And
I think, oh, sorry.
No, go ahead.
I was going to say, I think the other benefit is that, again, only 57% of students found these experiences beneficial. And I think that's really important because it points out that some of these experiences went really well. And some really may have not. So pointing towards, again, that further research is like figuring out what kind of stuff works, or did one thing work really well, like a category, but with varied results, like, independently or whatever. And is that instructor based? Is that because they did something different with their case study that didn't work too well, or did the person not feel prepared to teach or instruct based on it? There's a lot of variables there that can be broken down into additional, smaller areas of research that I think is going to be really important, especially for trying to get that student buy-in, because we can say, hey, what, students tend to really hate this one, so let's not go there right now, or look into changing
Hey,
it.
Sam, I think you have lots of work ahead of you. I look forward to see what you folks come up with, because you just gave yourself a whole bunch more to do. Just saying, that would have been something one of my PhD faculty would have said. Yes, you should write a paper. But this has been very interesting. Is there anybody else that wants to join our chat a little bit? Dr. Murph, you usually join in with us, and Janice Sinofsky usually join in a little more. Anything else you folks want to add? Oh, Janice has her hand up. Yay.
Okay, I just wanted to share an experience. We had the same opportunity to switch over very rapidly and use vSim. And we used our Lippincott products of vSim, and the students found the vSim at the beginning was fine. And then those students also got hired by the hospital to work as externs on the floor. And then they came back and they didn't like the vSim as much. And I was trying to figure out why. And I was asking the students, and they said, well, the vSim shows us what we're supposed to do, but that's not what we really see in the actual setting. Not realizing that during the pandemic, the hospital was under crisis mode for charting. They didn't have a lot of the PPE supplies that you would normally have. So there were accommodations made in the clinical setting that weren't made in the virtual sim setting. So the students found that it varied. They were supposed to be learning the right thing, but that's not what they were seeing in clinical. Did anybody else have that experience?
The PPE in particular, yeah, it was a big thing for us. Like, you know, I'd just been talking to students about it and we'd been practicing, and then, you know, never reuse this or whatever. And then suddenly it's all okay to use these for a month or whatever. And I think part of that's because a lot of these software things that were ready when we started with closures were not designed to show crisis situations. I mean, they were designed for business as usual nursing. And that's, you know, hopefully if supply chains sort of figure themselves out and that does not become a problem, we would maybe even see better results with some of these experiences, because there would not be such a disconnect or difference in what they're seeing in practice. There's always going to be some of that, like you'll maybe work with a nurse who doesn't follow the best technique, or you know, just not following policy or something like that. But at the end of the day, I think that you're right. There was a lot of experiences that were really different from the norm, and then that made what you were learning about and reading about is like, this is what you're going to see and do, not quite hit home as well as it should have.
Janice, I guess I would add too, our students were used to live simulations where they participating in them, working with each other, caring for these patients, and were actively using their skills. And when the pandemic hit, we weren't allowed in the building. And so that's when everything went to a more on paper, online kind of a product, like what you were talking about, VSIM, for example. And so they struggled because we were used to being involved and actively discussing and experiencing, and now all of a sudden we're answering questions. And so it seemed more rote to them. Perhaps that was a piece of it as well.
Well, we actually thought about having a debriefing after they did the VSIM, have a group debriefing. And so to bring all of the students back together, just with some asynchronous timing, it didn't work out that well. But I think that's something we're going to be looking at in the future is when we have the VSIM, is to bring them all together. They'll do the VSIMs independently, and then we'll bring them all back together and debrief together for that VSIM.
Yes, we did that, and it worked well. We were synchronous, so that probably made it a little bit easier, but it was an important facet.
I think debriefing is important no matter how we do it, for that very reason. I think that's where you learn. Anyone else have anything to add? We're getting up to 11:40. We had a break scheduled from 11:45 to 11:50. And then we've got to like 3 in the afternoon. So I think we just take a break from now to 11:50. Then we'll come back and start with our next speaker and just get right back on schedule. So if anyone has anything else to add, we can continue chatting. Otherwise, we'll go on break. Thank you, folks. I really enjoyed your presentation.
Thank you. We appreciate it.